Okay, hello, dear doctors, nurses, and the health team. Here we are going. How are you today? Here we are going to explain next question about cardiology, and it's very important. Okay, a 72-year-old woman is brought in by her husband as she has sudden chest discomfort, palpitations, and epigastric pain, which started 1 hour ago. She has been feeling nauseous. She denies pain radiating to the arms or neck. There are ST elevations seen on leads 2, 3, and AVF on the ECG. Oxygen has started. She has been given sublingual GTN and diamorphine, which has improved her chest pain. Her heart rate is 90 beats per minute and her respiratory rate is 18 breaths per minute. What's the single most appropriate next step in management? As we can see here, the patient had MI, and here we are going to explain which the next appropriate management what will be. Okay, low molecular weight heparin. B, percutaneous intervention or PCI. C, warfarin. D, streptokinase. And E, alteplase. And the most appropriate next step in management would be percutaneous intervention or PCI. And here we are going to explain it, why it's the single most appropriate next step in management of patients with MI. Okay, not all myocardial infarctions present with the typical cardiac chest pain symptoms. Some may present with atypical chest pain, which can be described as an ache or discomfort. Other atypical symptoms include abdominal discomfort or epigastric pain, as we can see in the history of this patient. As there is ST elevation in leads 1, 2, and AVF, this confirms the diagnosis of a myocardial infarction. And here is a very important note. Percutaneous intervention or PCI would be the best management for a myocardial infarction. Okay, as we can see in this ECG, we have a widespread ST elevation in leads 2, 3, and VF. We can see it in all the leads. Okay, also we can see ST depression in some of AVL lead, and in some of pericardial leads we can see also ST elevation. Okay, in lead 2 also we can see widespread ST elevation, and this is the feature of inferior MI. It means that the patient had inferior MI. Okay, myocardial infarction management. Okay, myocardial infarction management is tricky and it's always changing. Okay, a good way to remember the first few steps of managing myocardial infarction is to remember the mnemonic MONA. And M is for morphine, O is for oxygen, N is for nitrates, and A is for aspirin. Okay, aspirin 300 milligram. Okay, morphine is given intravenously to manage the patient pain. Oxygen is administered if there is evidence of hypoxia, pulmonary edema, or continuing myocardial ischemia. Nitrates such as GTN sublingual or by intravenous infusion are used to treat angina. Okay, aspirin 300 mg should be given preferably before arrival at the hospital. Clopidogrel 300 mg should also be given. Heparin unfractionated or a low molecular weight heparin, example enoxaparin sodium, should also be considered. Okay, for STEMIs or ST elevation MIs, current recommendations are to revascularize with percutaneous coronary intervention or PCI if within 12 hours of the onset of symptom, and if PCI can be delivered within 120 minutes of the time when fibrinolysis could have been given. Okay, this is the management. This was the conclusion of management the patients with MI, and here we are going to evaluate STEMI management summary. Okay, first, if the patient presents to the hospital with symptoms onset within 12 hours and PCI can be delivered within 120 minutes of the time when fibrinolysis could have been given, then perform PCI. But if PCI is not available and cannot be delivered within 120 minutes when fibrinolysis could have been given, thrombolysis or alteplase is a good choice. Okay, thrombolysis can only be done within 12 hours of the onset of the symptoms. Okay, 12 hours of symptoms onset. Okay, and here we are going to say something about post-myocardial management or heart failure and myocardial infarction. Okay, heart failure. If the patient has heart failure, AC inhibitors like enalapril, lisinopril, and ramipril will help for decreased mortality, and also beta blockers like bisoprolol, carvedilol, nebivolol, when initiate one at a time, will be helpful for decreasing the patient's mortality rate. Okay, we should also manage patient symptoms with furosemide, and we should add some spironolactone or digoxins if the patient has heart failure. Okay, and if the patient has MI but without heart failure, all patients with MI on discharge should receive dual antiplatelet therapy like aspirin plus clopidogrel. Okay, aspirin is continued lifelong and clopidogrel for 12 months. Beta blockers. Offer beta blocker to people who present acutely with MI as soon as they are hemodynamically stable, and continue a beta blocker for at least 12 months after an MI in people without heart failure. Okay, but if the patient has a heart failure, continue beta blocker indefinitely in people with heart failure. Okay, and ACE inhibitor. Offer ACE to people who present acutely with MI as soon as they are hemodynamically stable. If intolerant to ACE inhibitor, use angiotensin receptor blockers and plus statins. Statins also always must be considered in patients with MI or risk of MI. Here was the short explanation about MI or STEMI, ST elevation MI and post-MI management. The first thing we must see is the ST elevations in the patient's ECG. As we can see clearly in this ECG, ST elevation in lead 2, lead 1, lead 3, and AVF, and some of the precordial leads. Thank you for your attention.